Hello everyone, and welcome to our second video on the gross anatomy of the muscular system. Today we're going to focus primarily on the muscles of the head, neck, and trunk. And again, we're not learning where every single muscle is, what they do, how they attach. We are focused on some very specific muscles and some cool facts about the regionality of the muscles that will help you out in lab. So let's get started. So the first thing I want to go through with you guys are the muscles of the head. Now, pretty much every muscle on your head and face is responsible for facial expression. There are a couple that do other things like the temporalis and masseter, which are going to connect to that mandible and allow it to close. So they're responsible for things like mastication, helping with talking, things like that. Pretty much everything else, though, is going to be manipulating the skin on the face, and this is how we get our facial expressions. So we're actually going to learn some muscles in lab that are targets for things like Botox. So Botox, which we talked about in Chapter 10, the botulinum toxin, it's going to cause paralysis if you inject it into facial muscles. So when you do that, it causes muscles that might have excess tone in them on the face, and it relaxes them. So then, your 11s go away, frown lines can go away. So those are going to be some targets. Now, if a muscle is used for facial expression, where do you think it's generally going to originate or insert? Where do you think that would be? Remember, origination is the part that doesn't move, and insertion is the part that does move. So in the case of our facial muscles, the part that's moving is the face. So it is going to be, sorry, my computer is doing something silly. It is going to be found connecting or inserting into the face underneath the skin, and it's going to be originating onto the various different bumps and prominences on your skull. Now again, we're not going to go through every single muscle here, but I do want to point out 4 muscles for the face. And before I do that, we are going to go through a little exercise of don't believe everything that you find on the internet. This particular diagram I pulled because it is very pretty. It's of a model that has very chunky muscles, so they're easy to see. However, it's completely incorrect when you look at the labels. So be aware of that when you guys are making study materials, pulling other Quizlets, that not everything is correct. So first muscle we want to look at, we have our frontalis, which is our forehead muscle. Then we have our zygomaticus major, which if we follow this diagram, it's going to say it's right here. That is incorrect. Your zygomaticus major is this muscle here, connecting to the corner of your mouth. Then we have the orbicularis oris, which is actually the circular muscle around your lips. Notice they called that the orbicularis oculi. That's this guy here. And then lastly, we have our buccinator, which is a deep muscle here. You have a pad of fat called your buccal fat, and then deep to that is a sort of horizontal muscle called the buccinator. Why do we care? Let's start with the frontalis. So the frontalis's job is to raise your eyebrows. Now it's going to receive innervation or nervous stimulation from both sides of the brain, okay? And in the case of a stroke, for example, where patients typically are going to have like pretty much from here down, we're going to have some sort of facial drooping on one side, dependent on where the stroke is. Patients that are having a stroke can typically still raise their eyebrows, but they are probably going to have deficits in like their eyelid down here or pulling the corner of the mouth up. That's because of how the frontalis is innervated. Okay. Now, we have another nerve that's going to supply the entire face. You have the right side and the left side, and that is called the facial nerve. So the facial nerve is going to supply pretty much all of your face. And if you have something called Bell's palsy, which is affecting cranial nerve 7, that is going to affect all of the upper and lower portion of that side of the face. So people that have Bell's palsy oftentimes are going to have eyelid drooping. They won't be able to open that eyelid, and then also facial droop, and they can't lift the eyebrow on this side. So that is why the frontalis is so clinically important, because based off of what a patient can and cannot do, we can make some assessments as to what might be going on. Now, in terms of the zygomaticus major, this is also an important one. One of the things that we are taught in the field as EMTs when you're doing assessments for things like stroke is one of the categories that we check is smile. Can you smile? So if a patient is slurring their words or there's a suspected stroke, we say, can you smile for me? And if they can only pull up one side of the mouth and they can't pull down the other, that is one sign that there could be a stroke ongoing. The other two we have are actually really important for dental hygiene. So the orbicularis oris, one of the things that it does, we say, it closes the mouth, right? Or open, it's regulating the opening to the oral cavity. One of the things that the orbicularis oris does is something called lip seal. So it keeps basically your lips closed at rest. So you're not just like, mouth agape. So this keeps you from drooling. It keeps your food in your mouth, and it actually creates pressure within the oral cavity for talking. Okay? As you're moving your lips, sometimes you close the mouth to produce different sounds. So one of the things that your orbicularis oris does with lip seal is it actually helps keep your dentures in place. So elderly patients that you might be working on as a dental hygienist, they need to have good lip seal in order to keep their dentures in. So again, patients that might have neurological deficits from things like a stroke may not have the tone that they need in their lips, and that might be one of the reasons why their dentures are not staying the way they should. The buccinator, our deep horizontal muscle here, we learn the action as it compresses the cheeks. Okay, so it kind of pushes your cheeks in. What it's really doing is for things like chewing food, as you're chewing, the buccinator is going to compress and keep the food from pocketing. So what pocketing is when food slips in between the cheek and the gum line in the teeth here. And that, again, if you have a neurological deficit and you're unable to move your tongue properly, you may not be able to get those food pockets out. So the buccinator is really important for chewing your food. So if we lose any ability to function or have that muscle function, we're gonna have some problems. All right, now we're gonna move on to the anterior neck. So when you look at the anterior neck down here, actually you're only gonna see one sheet of muscle. So if we did a human dissection, we peel off that skin, the fat, the fascia. There's a very thin muscle down here. It kind of takes over this entire region of your neck down to your collarbone. So we call that the platysma. It's a very, very thin muscle. And you can see it, like if you try to pull you can tighten your neck. You can kind of see it kind of starting right there. It's a really thin muscle. And this is the muscle. As you get older, muscle fibers will start to separate. And that's where you get the turkey waddle, because it starts to lose tone, and then you'll kind of get that neck flaps down there. So that's coming from your platysma. When you reflect away the platysma, you're going to see a lot of small muscles, which we'll get to in a minute. But what you're also going to see is a pair of muscles that run from behind your ear down to the front, kind of like a little V. It's called your sternocleidomastoid. And it's a really important landmark muscle. So if you turn your head, oftentimes you'll see a thick muscle come down here, and you'll see the tendons, like right here at the collarbone and manubrium joint. What the sternocleidomastoid does is it creates a landmark for what we call the anterior and the posterior triangles. So the anterior triangle is everything anterior to the sternocleidomastoid, and it includes things like your submandibular salivary gland, your carotid arteries, and your internal jugular vein. Everything posterior to the sternocleidomastoid is going to house the posterior triangle. This is where we have our external jugular vein and our brachial plexus, which is a very important set of nerve networks that are supplying nervous stimulation to your upper shoulder and your arm all the way down to your fingers for both sensation and motor function. So why is this important? If you have a patient that has trauma in the front or the back, weak and penetrating trauma or whatever, we can make an assessment that one of those things could be a problem. In reality, though, it's really important for surgery. So if patients are coming in for cervical spinal fusion surgeries, or maybe they're having a thyroidectomy, we need to know, okay, here's the sternocleidomastoid. This is where some of those particularly important structures are going to be located. Now again, if we take off the platysma, this is what you're going to see. Here's the big sternocleidomastoid, and then a whole bunch of other muscles. These are a group of muscles that we call the hyoid muscles because they're going to attach to the hyoid bone. Now, their main job are going to be to either elevate or depress the hyoid. Some might also work on the mandible or the thyroid cartilage of your larynx. But overall, by moving that mandible, they're helping with the ability to swallow and the ability to speak. That's kind of the overarching goal. So when patients, again, have had a stroke, one of the things we might do is a swallow study to see if there is any impediment in that ability to swallow. So these might work, but there are other muscles within the face that could be a problem. Muscles that are going to come from above and attach to the superior aspect of the hyoid bone, they're called suprahyoid muscles. Muscles that are coming from inferior, so below the hyoid and attaching on that inferior surface, they're called infrahyoid muscles. That's really all I wanted to tell you because that's going to be important in lab for helping get all these guys straight. Now, we're going to skip the posterior neck because I want to talk about that with the back. So we're going to just kind of keep moving down and look at the anterior torso muscles. So these are muscles of the chest and abdomen, and we're going to start off with our chest muscles. So we have a lot of muscles of the chest, that's basically everything above the diaphragm. And they have a lot of different roles. Some of them are going to help stabilize your scapula. Some of them are going to help with breathing, like our intercostals. Some are actually going to move the shoulder joint itself, okay? So the three that I wanted to bring to your attention are the serratus anterior, which are the little riblets right here, the pectoralis major, which are your pecs, and then your pectoralis minor, which is deep to that. So the pectoralis major's job is to flex, so flex, and then adduct and internally rotate your arm, okay? It does a lot when you're doing a lot of pushing motions, so bench press, push-ups. That is your pec, okay? Now, why are we bringing this to your attention? In a lot of individuals, their pecs can be really tight, whether it's from just not stretching or from lack of use. They just get tight, and then what happens is your shoulders round. So here is normal posture, and if your pecs get tight, they will round. And sometimes this happens too with injury. Our muscles like to seize up. So if you have rounding of the shoulders, that is actually something that's going on with your pectoralis major and your pectoralis minor muscles. So we actually use our pec major a lot when we're doing shoulder rehab. You'll do a lot of, sometimes we'll do some pushing motions. We will do various different things that are going to help relax that pec, and because it is connecting to the scapula at the coracoid process, we need to also strengthen it, especially if you have an unstable shoulder. Now, the pec minor, which is going to be deep to that, it's going to be involved in protraction, which is kind of bringing the shoulders forward, and depressing the scapula, so pulling it down. So you just kind of round your shoulders and then pull them down, and that is going to be your pectoralis minor. Again, if it is tight, because it's going to the same, you can see on the screen, it's kind of going to the same position, it'll also aid in those rounded shoulders. And it can contribute to something we'll talk about later called thoracic outlet syndrome. There is your collarbone right here, and then you have rib 1. And there is a finite amount of space between there, through which we have a vein, an artery, and the brachial plexus running through. And one of the things that our muscles love to do when they get injured or irritated is swell. And so if that happens to your pec minor, if it swells, it can contribute to that syndrome, leading to pain and other issues. So this is really important for patients that have things like shoulder impingement, which again, you're going to have pinching and decreased range of motion in the shoulder joint, because that's where the pectoralis minor is also inserting. And then you can also use for stretching to help when you put your hand up against a door frame, kind of lean forward, you will feel that stretch right there, and that's going to help with the pec major and pec minor and reduce that sort of rounding. Now the last one we want to talk about is your serratus anterior. So it's going to be the muscles that are right here along your rib cage, and these ones are also going to be involved in protraction, so pushing the shoulder blade forward. Okay, so again, neutral, pushing forward, protraction, as well as rotating your scapula up. This is a big muscle that's hit in physical therapy, especially for patients like myself that have multidirectional instability. The number of dumbbell protractions I had to do was insane. If we can strengthen that serratus, we can help ensure that the scapula stays more stable, and so it's going to help reduce any further dislocations. One of the ways you can work on your serratus early on in your physical therapy series is by doing wall slides. So you kind of stand as close as you can to the wall, and usually you have a towel, and you just move your arms all the way up and then all the way down, and that is doing that upward rotation of your scapula. Okay, on to the abdominal muscles. So we have a lot of abdominal muscles. Running down the center, you have your abs. Those are your rectus abdominis, your six-pack. Then we have two muscles that are going to come at this angle. Those are called your external obliques. And then we're going to have a muscle that, where is my camera? There we go. So external oblique, internal oblique. Internal is deep, external is superficial. Notice they are running at different angles. And then even deep to that, we're going to have another muscle that runs at a horizontal. So we have one muscle vertical down the middle, one muscle that wraps around horizontally, and then two muscles on the sides that go like this. Having these different fiber directions is really important because it's going to give us that strength and stability that we need in that region of our torso. This abdominal region has no bones. You have your vertebra in the back, but nothing in the front. And so the muscles of the abdomen are going to provide strength and stability, but also protection to those internal organs. Now, they are going to all meet together. You can kind of see this white tissue here. That is called the linea alba. It's basically a flat tendon, and it's going to run from the end of your sternum down to your pubic bone. And that is kind of one of our attachment sites for these muscles. And here's our first big real clinical connection, diastasis recti. One thing that can happen in pregnancy, and I'm going to tell you so many things as we approach that in class, one of the things that can happen is as the fetus develops, it's going to push out on your abdominal wall. And in some women, and it doesn't matter your strength going into pregnancy or not, they are just more prone to having that linea alba where the rectus abdominis, this is my rectus abdominis, as the fetus pushes, it will separate the rectus abdominis. Now, in some women, this will go back. It may not be that severe, and it may just go back to normal. In other women, like those you see on the screen, it is split a lot. And that can kind of lead to some pooching. It leads to, you can see indentations in some women. And typically the treatment here is going to be physical therapy. If it's really severe, they could do surgery to stitch it back together. It is more than a cosmetic issue. Every time you have any intra-abdominal pressure, coughing, sneezing, and stuff, it's going to bulge out, and you could continue to have it get larger. So it is something to be checked out. It is not considered normal just because it happens. Okay, while we're still on the anterior torso, let's take a look at some of these deeper muscles of the chest. So the first one we want to talk about is our diaphragm. This is an inferior view. Here's your diaphragm right here. It's a C-shaped muscle. And what it does, in a nutshell, is when you breathe, it's going to pull down. And what that does is it increases the volume in your chest cavity and causes air to rush in. And when that muscle relaxes and goes back to its original shape, the air gets pushed out passively. To assist with that enlargement of your chest cavity, we have our external intercostals. These are the ones that are going to be kind of running towards the outside of your chest wall, and they are going to help pull your ribs up. So the diaphragm goes down, external intercostals help pull the ribs up, bigger volume, now we can breathe. Your internal intercostals are going to run at this angle. They are deep, so they lie underneath the external intercostals. And when you are exhaling forcefully, coughing, laughing, they're going to constrict the ribs and help force the air out. Okay, so the internal intercostals along with your abdominal muscles are considered accessory muscles for respiration because they can be used to help forcefully push air out. Now we have another set of muscles that can assist in breathing that are going to be here in your neck. So we have our sternocleidomastoid, and then deep to that and a little posterior is a set of 3 muscles that we call the scalenes. Now the scalenes are going to connect to your cervical vertebrae and attach to the first 2 ribs of the rib cage. Their job is to move your neck, okay, but also when you're taking deep breaths or you're having difficulty breathing, these guys will get activated. They're going to help pull those first 2 ribs up as high as they can to try to get even more volume in your chest cavity. So we will see what are called retractions. So you'll see like sucking in. You can see it in between the ribs. You can see it here in the neck for people that are in respiratory distress. And again, these guys are connecting to the first rib. And what do we have by the first rib? The clavicle, and a very small region of space for which the scalenes to attach. The pectoralis major is going to kind of run right, or minor is going to run right by there. We also have our subclavian artery and vein and our brachial plexus. So if that region gets compressed, it can compress the artery, vein, and or nerves. And that's where you'll get things like paresthesia, which is like pins and needles of your hands. You can cut off blood flow if you raise your arms above your head. So then again, more paresthesia. So that is what thoracic outlet syndrome is. There's a lot of different treatments for it. Some of the extreme ones would be to remove that first rib. But I just like to talk about it because it's kind of a cool thing. All right, on to the posterior neck and torso muscles. One thing I want to talk about with your back muscles is a lot of the back muscles we see on this diagram are not actually working on the spinal column. I want to focus today on the ones that are moving the head and like moving the spinal column. A lot of these, like the trapezius is one of them that will move the head, but it also primarily is going to work on the arm. Latissimus dorsi, the big muscle back here. All of our teres major muscles are rhomboids. They're on the back, but they're acting on the scapula or the upper arm. So we're going to talk about them in our next video. What I want to take a look at right now are a group of several muscles that are acting primarily on the spine itself. So the muscles that are moving the vertebral column, as we will see, are they're wild. If you look them up in your textbook, if you look up their origins and insertions, they are crazy because they're like the different transverse or posterior or spinous processes of different vertebrae. There's a lot of overlap. It's insane. So we don't care in our class. We also don't care about the individual muscles here. We are working on groups. So when you see things, I mean, I will talk about the multifidus, we'll look at things like the splenius capitis, but in reality, we're not super responsible for knowing all of those. The main things these muscles all have in common is they're going to extend your neck, which again, here is neutral, extension, flexion. So because they're on the back of the skull, when they contract, they're going to pull and extend the neck, and they'll also do trunk extension. I can't do trunk extension with the tiny video I have, but you can pretend I lean forward, that's flexion. I'm using my abdominal muscles, but now I need to go back to neutral. So I'm going to use my back muscles that we're going to look at to go and extend my back. So flexion and extension. And then we can also do lateral flexion, which is just like your little teapot. So here are the 3 groups that we want to take a look at. The Erector spinae, which is going to be a huge group of like 3 different muscles, the transversospinalis, and the segmental muscles. So let's start at the top with the Erector spinae. Their job, sole job, is to extend the vertebral column. So we've done a crunch, now we got to go back, or we want to lean back, anything like that. They're extending your vertebral column. And you can see it's this group of 3 muscles. We've got the big back one right here with the iliocostalis. We have a longissimus and the spinalis. And you'll see that they run up through the entire spine up until about the cervical spine. Why do we care? These are typically muscles that are involved in lower back pain. And if they are weak, if you notice, they're going to be connecting to this thoracic vertebrae. And if they are weak, they're not going to be able to maintain posture. So what will happen is on that sort of far end, it'll get weaker and you'll end up with a rounded back. So you'll end up with something like kyphosis, where that thoracic curvature is more exaggerated. Okay. Those of you that work in customer service or already are nurses and are on your feet all the time, you know that if you don't have the right shoes, the right mats, your lower back is going to hurt really bad because of these muscles. They are often exacerbated and overused, people that have to stand for a long period of time. Now the transversospinalis, these are a group of several different muscles, like the multifidus semispinalis, and they also are involved in extending the vertebral column, bringing it back to neutral. Because they run along both sides in the way they are connected to the spine, they can also help with rotation. So if only one side contracts, we can also rotate, or we can just do extension. And they're also, along with the segmental muscles, help ensure your spine is stabilized. So it's not like wibbly wobbly, but it stays in that alignment. Why do we care? Two muscles here. The multifidus, which there's different spellings for it, that is the one, when you are training your core, it is going to also help. So people often complain about back pain, and really it's because you have a weak core. Your abdominal muscles are too weak, so the back muscles have to do a lot more work than they need to. When you are doing things like planks, not crunches, but planks, or anything else where you have to stabilize your core, farmer carries and things like that, you are also activating the multifidus muscle. And it's going to be there to help make sure that, like when you're doing your farmer carry, you carry a very heavy weight on one side, you're not leaning forward, you're not leaning backward. It's helping maintain your posture. And that's really going to help with overall back pain. Another one is your semispinalis capitis. So the semispinalis capitis is going to run all the way up to the base of the skull. And those of you that get tension headaches, that's the one you can be mad at. Depending on that contraction of that muscle, it can contribute to tension headaches, which is why when you rub the back of your neck there, when you have a tension headache, it kind of helps make it feel better. Now, the last muscles I want to look at are these tiny little muscles that are connected to different processes on each individual vertebra, called the segmental muscles. Again, they're going to do the same thing. They can do lateral flexion, they can extend the vertebral column, but what is their main job? Posture. What they do is each one of these muscles has what we call a high density of muscle spindles. Muscle spindles are a organ you're going to learn more about, or a component of an organ you're going to learn more about in physiology when you get to reflexes. They are going to let the brain know where that muscle is in space. And so because these guys have so many of them, they can make small little adjustments to help maintain our posture. So that's what the segmental muscles are really doing, is helping maintain posture. So that's it. We've made it through 2. We have 2 more videos to go, and I'll see you then.